Well, good afternoon, everybody. I'm incredibly excited to introduce Carilion researchers and research coordinators, Dr. Glenn Edwards, who's the chief of the Pediatric Hematology Oncology Section and Children's Oncology Group PI for Carilion Children's, as well as a co-chair of the Carilion IRB, and Wendy McCarty, who is a clinical research coordinator and is the only one to hold this position to now, and has been with Carilion for 30 years. So an expert on the research coordination. And Sydney Moses, a pediatric oncology clinical research coordinator, started in August, a graduate of Virginia Tech. And before being a CRC, Sydney did preclinical mouse model research for brain disease and glaucoma. I'm going to turn it over to our speakers today to talk about their work. If you put something in the chat, I will be moderating it, and we'll have time at the end for any questions. You can either put them in the chat, or you can raise your hand or speak out, and we'll be happy to answer them. Take it away.
Thank you. Good afternoon. So I'm here with Wendy McCarty and Sydney Moses. And just in case you run into us on the street, this is who we look like and a couple of the other docs on our team here. So we've been asked to talk about pediatric oncology research and to kind of tell people what we do here. And so we have a little bit of an outline. We're going to break this up between the three of us and give this in parts. So we're going to I'll start out with a little bit of a brief history. I think that's sometimes helpful just to give a little background on how we got where we are, and the progress that we've made over time, maybe some of the mistakes that we made, some of the successes that we've had. We'll talk a little bit about ethics of pediatric research, since children can't consent for themselves. And, is this an ethical thing to do to or for children? And then we'll talk about children as a vulnerable group, because children are not little adults. And so we'll go through some of that and some of the regulations involved there. Then Wendy's going to take over and talk about the pediatric oncology groups. Sydney's going to talk about some of the differences between pediatric oncology and the adult side, what we do and how we differ. And then I'll close out with, talk specifically about our practice here and just some of the things that we're looking forward to doing in the future. So just as a brief history, the first pediatric cancer unit opened in the United States in 1939. But there really wasn't any known or actually beneficial treatment for cancer until the 1940s. And that was when Dr. Farber described the temporary remissions by administering an antifolate that he had gotten from Yella Subarow. And before that time, the treatment for cancer was really just supportive care, comfort care. There was some surgery done for local tumors, which was called extirpation, but even that oftentimes failed fairly quickly because of micrometastases and frequent relapses. And actually, when Dr. Farber published his work, and when he first started treating these children with leukemia, there was a lot of opposition, and that he was just causing more suffering for these children because the initial therapies didn't work very well. In the 1950s, there was development of additional active agents, and the first cooperative groups were formed, and the NCI was found. And those first cooperative groups were mainly focused on the treatment of leukemia. It was the acute leukemia group A's and B's, which the pediatric branches of those would subsequently become the CCG in 1974. And then the acute leukemia group B would become the cancer and acute leukemia group B and the Southwest Oncology group, which that pediatric part of that would become the pediatric oncology group in 1980. In the 60s was the advent of combination chemotherapy, and there were a few more successes in terms of remissions of cancer, but there were all too frequently relapses, and the remissions were not long sustained. In 1969, the third pediatric oncology group was formed called the National Wilms Tumor Study Group. And this was a very successful group that within a decade of its formation made several discoveries, one of which showed that radiation therapy was not necessary in the treatment of stage 1 or completely resected Wilms tumor. And they also developed multi-agent chemotherapy that yielded greater than 90% survival with low treatment-related morbidity in these children. In the 1960s, St. Jude was also founded with a mandate to develop a cure for childhood leukemia, and they developed something called total therapy, which was a really huge stride in preventing relapses, which were primarily CNS relapses or sanctuary site relapses in children with ALL. And then in 1972, the fourth pediatric group was founded called the Intergroup Rhabdomyosarcoma Study Group. And finally, in 2000, all of these groups merged together to form what's now called the Children's Oncology Group. And that's really, it's the largest cooperative oncology group, I believe, worldwide, and is really the main pediatric cooperative oncology group in the world. So advances, there's been a lot of advances made primarily with the under the guise of these cooperative groups, where you can take a really rare disorder, overall pediatric cancer, and combine resources and protocols and accrue patients in a much more rapid manner than you'd be able to as a single institution. And this has made great advances. In 1940, before the advent of any successful therapy, the average survival for acute leukemia was only or less than 3 months. By 1965, there was a world survey that was conducted where they only found 71 children that survived after diagnosis, either with or without disease at that time. And then by the late 60s, the survival was still only 5%. And that was before the development of total T therapy. Currently, the survival for all comers of childhood leukemia is greater than 90%. And you can see in this graph, these are curves by date of or year or time frame of diagnosis. There's this huge jump from 1970 to 72 up to 72 and 75, and that was with the advent of total T therapy and successful CNS prophylaxis with radiation and chemotherapy. If we look at a few, these are just a few examples from the 60s to the present. All pediatric cancers have, the long-term survival has improved from 20% up to 86%. Wilms tumor from 30 to greater than 90%, bone tumors from 10 to 72%. And one of the more recent successes has been high-risk neuroblastoma, where survival was unheard of in the 60s. And even in the 80s, the survival of high-risk neuroblastoma was less than 15%. And now with the advent of immunotherapy and high-dose chemotherapy with stem cell rescue, the survival is up to 65%. And even though that's great in terms of strides, there's still a lot of work to be done. But overall, pediatric cancer, with the work that's been done, is actually now in most cases a very treatable disease. And these are some of the survival rates for some of the more common classes of childhood leukemia. So this progress has come about mostly by through collaborative trials, but also advances in cancer pathobiology, development of novel therapeutics, especially in the realm of immunotherapy and targeted therapies, diagnostic imaging improvements in radiation technology, supportive care, and then also recognition of late effects. Right now, it's estimated that there are probably about 500,000 adult survivors of childhood cancer in the world. And so long-term late effects are really playing an impact in those patients. And that's an area that we hope to improve on in the future. So how is pediatric research even ethical? Are we able to do this research in an ethical way in children that can't understand, that don't have the cognitive or reasoning ability to make decisions and provide consent on their own? Well, they're not little adults. So the diseases are actually different. So there are some conditions that are limited to pediatrics or that are more prevalent in children where we couldn't really do the research in the adult or older population. There are differences in children. Children have different dose-limiting toxicity levels to different drugs. There's an impact on a growing and development or on growth and development that you don't have in older patients or adults, especially one area would be the effect of radiation on developing nervous system. And then there's dosing differences, and these are just a few examples. So in infants, if you dose based on body surface area, which is what we typically do for most chemotherapeutic agents, you're going to overdose them. So we have to use different dosing and typically use weight-based therapy just because their weight to body surface ratio is different than it is in adults. There's an effect of age on outcome. Even within the pediatric population, there are times where younger patients may do worse or better than older patients, even with the same disease. For instance, with acute leukemia, the patients that are in the 1 to 10-year-old range do much better than those of older patients in the teenage years. And so those may be, and there may be prognostic indications just based on age. And that's become important, especially in acute leukemia therapy, where now we've developed this risk-adapted therapy. And age is actually one of those prognostic indicators and risk factors. So the other thing in terms of being able to do pediatric research is, and one of the first ethical rationales was that there may be accepted treatment or therapy that's not validated, that may be potentially harmful or ineffective, and there's no way really to sort those out without doing appropriate research. So, this was something early on that was an issue in terms of the ethics. With the initial treatments for leukemia, a lot of these children ended up dying from their disease anyway. And so a lot of people were opposed to the initial therapy, saying you were just prolonging their suffering. Fortunately, the advent of effective therapies came along fairly quickly and dispelled those fears. So how do we conduct pediatric research in an ethical manner? Well, pediatrics, of course, is a vulnerable group. They can't understand always the research. They don't have the ability to make decisions for themselves because they don't have the cognitive or the reasoning ability. But there are protections that have been put in place, and so to protect them as a vulnerable group. The significant developments in that area. One of those was a National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research that met in 1977 and made recommendations regarding research involving children to establish certain protections that were different from already accepted practices in human research. And this was later codified in 45 CFR Part 46, mostly in Subpart D. So what this did, and I'll just discuss this briefly, is that it provided some exemptions, or it removed some exemptions from accepted practices. And for example, research involving observation, test surveys, and interviews. These were no longer exempt from IRB approval and review. There had to be provision made for parental, guardian, or some other legally authorized representative to give permission for the child to participate in the research. And there also had to be provision made for child assent. And children consent, go back to consent. Consent can only be given by the individual that it applies to. So parents can't really give consent in a legal respect. For their children, they can only give permission. And then the children, if they're old enough, can give assent to participate in the research. And of course, there are some exceptions for this. For instance, if a child is in a situation like child abuse and there's research being done in that area, parental permission isn't required. Or if it's deemed that participation in research provides a benefit to the child that couldn't otherwise be realized, then the child can be participate in that research with parental permission without their assent. But generally, parental permission and both parental permission and child assent is required. And Wendy's going to talk a little bit more about this later on in terms of the age, consent being, or permission and assent being a continual process. So the other restriction is that it limited what an IRB could approve in terms of research. There are 4 categories, and the IRB was limited approval in 3. So they could approve research that was no more than minimal risk. They could approve research that was greater than minimal risk, but had a prospect of direct benefit to the individual or to the child. And then greater than minimal risk, if it did not have the prospect of direct benefit, that there were restricted risk and generalizable, and the expectation that there would be generalizable results. If it does not fall into those 3 categories, then it requires review by the Health and Human Services Secretary in order for that research to be conducted. And my computer isn't working. Ah, there it goes. So Wendy's going to take over now, and she's going to talk a bit about cooperative oncology groups and what it means to participate in those studies and what we do here.
I'll pull my chair. Okay. Hi, I'm Wendy McCarty. So with doing what I want to say, having the cooperative group helps us to have the studies all over the United States, and that way we can have more participation and get to the results sooner. We have about 200 institutions worldwide. They have institutions in Australia, New Zealand, and I've always tried to go to Australia to help do an audit there, but they keep telling me no. So, but we have everywhere. So you want to be treated. If you have a child with cancer, you want them to be treated at a COG institution. There's about 10,000 cancer specialists, and that's the MDs, the nursing, the CRAs, social workers,
Pharmacists.
the pharmacists. We try to incorporate everybody. Specifically, we have radiologists, radiation oncologists that work specifically within the children's oncology group. Where am I pushing here? So we've been a member of COG, well, the history of it. We started out as a pediatric oncology member, and that was back in 1995. And I joined the practice in 96, I believe. And we do therapeutic trials, and we do non-therapeutic trials. And you're going to discuss this, right? Okay, so I won't go into that. But we typically see every child from infant to 18. And then there are some diseases that are older than that allow an older age group. More recently, I've been amazed that we are finding babies born with cancer, or what may be cancer, on the mom's ultrasound. So that's how good technology has come with the mom's ultrasound. And Dr. Edwards, I really don't want to talk about the MCI because I don't really know that much about it. So if you want to jump in here and go at it, we can.
Okay. So the MCI is
fairly new.
It's fairly new within the last couple of years. MCI stands for Molecular Characterization Initiative. It's part of a non-therapeutic study which incorporates a database and also some pathology called Project Every Child. And MCI, this is available up to the age of 25 years, and it's completely funded. So this testing, they can perform molecular testing of certain diagnoses. Started out with CNS, and they do whole exome sequencing. They do methylation studies and other molecular tests, looking for targets for targeted therapy. And also there's some provisions in there of looking for eligibility for enrollment on certain therapeutic protocols. The turnaround has been amazing. When they first developed this, they said the target was going to be 3 weeks, and the turnaround time now, the mean turnaround time is about 2 weeks for this, which is really amazing to get all of these tests back. And it's completely grant funded as long as they're enrolled on the protocol. So there's no cost of this to the patient. And there's also a provision here for tissue banking and for future research, and they can opt out of any of those things that they want to. But we're hoping that we can, get some older patients enrolled in this, patients that we wouldn't necessarily see, but maybe the adults would, and get some of these patients between 18 and 25 enrolled in some of these tests. So that's the MCI. It's a very exciting program that's being run through the Children's Oncology Group.
I mean, not only does it do the CNS, it also does neuroblastoma and sarcomas
And rare tumors.
So, and eventually I think they'll be opening up to renal tumors within the next year. And that's one of our patients on his last chemo day. So we have a person who makes these cakes for us with the Carilion Children's butterfly. And the necklace that he has on, they are hero beads. So he gets a bead for like coming to clinic, getting his labs done, getting his port access, taking his oral chemo at home. And so we have a party celebration for him. And he was really excited that day, which of course we all were. And this little girl here's another patient. Claire Parker was a patient who, she was an infant, she had infant leukemia, and unfortunately passed away. And her parents started this Claire Parker Foundation, which gives us a snack card, which they completely fund for us. You know, they bring food in every month every other month or something. So that's a nice little, actually more stuff than the hospital provides for us. We work with the Pediatric CIRB through the NCI. Back in 2013, the government, and I can't remember why we had to start using it, but it was a fun couple of months trying to get all of our studies switched over from the Carilion IRB to this one. Meredith and I had just tons and tons of fun with it. And of course, you know, a pediatric study, like the leukemia studies between my average risk study and the high risk studies, there are 9 consent forms, or 10. They're 10. Yeah. So I had to redo all the consent forms, and it was a process. But it does, I don't think it makes opening studies easier. If I just had to use the pediatric CIRB and not go through, first process it through the Carilion one, which is a shorter process than just one through there. But it's nice that we have that now, because it makes things quicker to do with the opening of the studies. So, and the consent process. So as a CRC, Sydney and I do not consent or get permission from our patients. That is done strictly by the MDs. Now we go with them, you know, to make sure everything, all the I's are dotted and T's are crossed. So the parents give that, like he said, the permission. And then once the patient reaches 18, that's when we get consent from them. And it's the age of majority by state. In the state of Virginia, it is 18. We do use something called youth information sheets, which explains the process. They're broken down by age, 7 to 12, 13 to 17. And it explains what's going on in their language, their reading, hopefully their reading skills. So we do use those with the sheets, and they don't have to sign anything. We do have some teenagers that will sign just because they want to, the consent. But it's the parent giving the permission. So, like I said, the Children's Oncology Group, we have 200 of them, over 200. I think it's like 210. They have 100 studies opening. We have, I think, 20 23, I think we just put 20 to 23, I think we just closed one. And so, you know, we want to capture, if you have cancer on your nose or on your toes, we want to encompass the whole body. So that's why we have so many open. So we can say, if, you know, somebody comes in with something, we are able to offer them a clinical trial. Am I doing this or are you doing this? I'm still doing this. Okay. So, so a lot of times our studies are open for a very, very long time. We do follow up for 10 years on a phase 3 trial. 10 years from the time the patient is enrolled is how we follow them, each for 10 years. But the study can be open much longer. I think the major, not the last ALL study, but the one before that was open for 18 years to complete everybody to complete follow-up. So it is a long time, and that's a lot of IRB work to keep open. The one thing I really found interesting a couple years ago with the T-cell study, the 0434, that they had found out that Nelarabine had a significant, patients who received Nelarabine had a significant survival rate. So the T-cell study that was open at the time, the 1231, was closed down, and we were given instructions on, you know, to offer the Nelarabine to the patients who were on the 1231. And if they accepted it, we would have to take them off study, but we were willing to do that just because it was a better survival rate. Adverse events, they have study specific adverse events that are laid out in a section of the protocol. And they tell us, you know, they don't want to see, if it's not a grade 3 or above for something, we don't have to report it. But then there'll be ones like, if a patient has a seizure, no matter what grade that is, they want to see it. And it specifically tells you those things. The other thing about COG protocols, and I'll just throw this in, is that you can go to any COG protocol, and I know that section 3 is going to be eligibility. I know section 6 is drug information. And that's how every single protocol is laid out, unlike industry studies where it's kind of put together how they seem fit to do it. But that's the one good thing about the COG studies that I like. So as I said, we mainly do phase 3 studies here because most of the phase 1s, they have COG has their own phase 1 group. And those are institutions that are larger, that are going to see more of that disease population. We do some phase 2 studies if they're group wide. But we really don't get into the anything pilot, phase 1, phase 2. Sometimes they'll have a non-therapeutic pilot study when they're trying something out, or wanting to look into it, I should say, and we can participate in that. But you have to go in and look to see if it's group wide or limited institution. That's you.
Come up here. It's like doing a little merry-go-round. Oh. Okay, I'm Sydney. I just started in August, so Wendy has been doing this job by herself for 28 years. So it is a learning process. But I'm basically, it's really interesting to me to see how the pediatric oncology research is different than all the other researches that I've seen, based on like going around and looking and shadowing other research coordinators to learn the job. So here at the Pediatric Oncology Clinic, we do both therapeutic and non-therapeutic studies. So with our therapeutic studies, you see chemotherapy, surgery, radiation, transplant, and like Wendy mentioned before, that baby the mother had an ultrasound and the baby showed a tumor. The tumor ended up being neuroblastoma. So in that situation, it is considered therapeutic because we're still watching the tumor. But so Wendy and I actually go to the OR with the physicians. So we went to the OR to collect the samples of this baby And ever since we just observe her disease, such as looking at scans, since there are really no more things to be shipped out. And also our therapeutic studies can be a combination between like chemotherapy and surgery, chemotherapy and radiation, or any of them. But me and Wendy deal with a protocol. It's called APEC 14B1, which is called the Project Every Child Study. And we're basically trying to get every single child that comes through our clinic that has a tumor or a cancer on this study. It includes a registry, quality of life questionnaires that ask you, how your child is coping with cancer or how the child is coping with cancer. It studies the late effects. So later in life, if you develop like a syndrome or something, it could be related to cancer, cancer control, biology. So me and Wendy ship out a lot of biologics. We probably ship out something maybe once a week.
Yeah.
Yeah.
Something.
And we also look at neurocognitive. It's becoming a big part of research. We actually use a software called Cogstate. It's not through the Children's Oncology Group. It's kind of like its own thing, but it partners with the Children's Oncology Group. It tests memory in children with cancer. And don't even get me in when he started on this Cogstate program. It took us forever.
We had to do the test.
Yes. It was awful.
Needless to say, we need to work on our memory.
Yes, we do. And we also have a psychologist that has the official dynamic of all the tests performed in our cancer children. So here is an example of some of the protocols. Like Wendy mentioned before, the follow-up for COG studies, for phase 3 studies is 10 years. A lot of people do not realize that we keep up with our patients for 10 years. Whenever we say 10 years, we mean 10 years. We keep in contact with them once a year until their 10-year mark of being enrolled on the study. We just finished follow-up on patients who were enrolled in studies back in 2013. Phase 2 studies, follow-up is just 5 years from the time they enroll on studies, but we mostly deal with phase 3 studies, I would say. Studies are open for a really long time because they want to capture everyone in follow-up, like Wendy mentioned before. We had this neuroblastoma study. It was called AMBL00B1. It opened in 2000, before I was born. And we just closed it. It will stay open until the last person finishes follow-up. And the baby that was captured on the mother's ultrasound, she was enrolled in that study back in December. So 10 years from whenever she finishes. Some of our naming conventions, we have like a set way of how our protocols are named. So the AALL 1731, which I would say is our most used therapeutic protocol, it's for acute lymphoblastic leukemia. So A is the cooperative group code. So all of the protocols will start with A. ALL is the disease code. So acute lymphoblastic leukemia. 17 is the year of the anticipated study opening. And 1 is the phase studies open that year. So AALL 1731 was the first phase 3 study planned to open in 2017, and it actually opened in 2019. Here's a picture of one of our patients. He has his little portrait on. I thought it was fun to include that in there. But for our APEC study, the Project Every Child study, like I had mentioned before, we currently have 93 individuals enrolled at Carilion Clinic. It is the backbone of all protocols. So a lot of times, APEC is a requirement to be able to enroll on other studies. So for the 1731 protocol, APEC is a requirement for the participant to enroll on APEC and the 1731. For APEC, we have a manual of procedures. In this book, it is different than a protocol. It entails shipping guidelines, what is required to be enrolled on a therapeutic study, how to ship stuff, how much biospecimens you need. It also has guidance towards other protocols. It's basically mine and Wendy's Bible, I would say, for this study. And then we have like 5 or 6 parts of the Project Every Child protocol. So part A includes eligibility screening, molecular characterization, which is the MCI that Dr. Edwards talked about. It looks at genetic material and mutations for certain diagnoses and rare tumors. We also do biobanking for future research that people can consent to. Part B includes tracking outcome. Oh gosh. Registry and contact for future research. So if COG was to open up another trial, we could contact the patients and be like, hey, you may be contacted for this trial in the future. Parental biospecimen is where we collect blood or saliva samples from one or both parents. And right now it's just for banking purposes. They just keep it in a locked lab, but they plan to use the parental biospecimens in the future. And we also use an additional bone marrow consent. It's something that we would use if we get a quick case. And another thing with pediatric research is that once a patient walks through the door or gets admitted into the emergency room, we jump on it. Like, I was going to be remote one day and I got a text at 10 o'clock at night saying, we have a new patient, so we have to do a bone marrow in the morning. And there went my plans. It is a lot different than the adult world, because in the adult world, you have to wait 3 to 6 months to be able to see from a doctor. Our patients get treated usually in the next week, I would say. We also do post-mortem samples, a part of the Project Every Child. So if one of our cancer patients was to pass away, the parents can consent for us to use their biospecimen to be shipped out to learn more about the child's cancer. So like I had mentioned before, AALL 1731 and 1732 are our most used leukemia protocols right now. We have about 6 to 10 patients on these. APEC 14B1 is required to be able to enroll on these studies. We screen between these two protocols based on age and white blood cell count. So if someone is above the age of 10, they're automatically offered 1731 if they're eligible. And if their white blood cell count is above 50,000, they're automatically offered 1732. So if their white blood cell count was 49,000, they would be offered 1731. And Wendy and I help the doctors with bone marrows. And I included this little picture because a lot of people don't know where bone marrow really is. It's like a pack of cells in your bone. Me and Wendy go to the procedure with the physicians, and we have our own little kit that includes sterile supplies, blood collection materials, bone marrow biopsy, and aspirate needles to use in the procedure. We help the physician by setting up a sterile field and collecting the bone marrow samples. And Wendy and I have performed procedures inpatient, outpatient, in the OR, and even in the emergency department and MRI. So that was interesting. Okay, this is the COG overall enrollment for the Project Every Child study. It currently has 52,000, almost 53,000 participants on it, and they want to have 75,000. It is the biology studies of all biology studies, and it is open to every child with cancer besides renal cancer. And then here's some numbers on 1731. They currently have a little over 4,000, but they want to have 6,700. And then on 1732, they have just a little over 3,000 and want to have 5,000. So you may be asking, what are the differences in pediatric oncology research? Me and Wendy see a lot of different types of cancer trials. So I did like my learning in gynecology oncology. It's a whole different world over there. We see leukemia, lymphoma, sarcomas,
Brain tumors.
Brain tumors. We see everything. And like Wendy likes to say that Roanoke is weird because we see everything. Wendy and I help with procedures. A lot of CRAs or CRCs do not help with procedures. And it's really fun to be able to like be close with the physicians and like go into the OR and scrub up, and it's just really interesting. Like I had mentioned before, the pediatrics, they're really quick to get their treatment. And Wendy and I also make calendars for patients. I'll show you a roadmap in a couple of slides, but this is an example of a calendar that we would give a patient that takes oral chemo, because sometimes it's hard for them to keep up when they need to come in clinic, what dosage they need to take what day. And I mean, they're little anyways, and the parents can get overwhelmed. We randomize based on stage of cancer. So that means some cancers are placed straight into an arm if you have standard risk, but you can also be randomized if you have standard risk average or standard risk high based on the results of the diagnostic test that we would run or the bone marrow results. Even if you decline enrollment or are not eligible for the study, 99% of our patients get treated as per a COG study, which means they would not get a COG number, but we would still enroll them based on like the standard of treatment. The do nots that we don't do that's different than, I would say, industry studies. Me and Wendy do not consent. We go in with the physicians to talk to the parents because we basically know the protocol front to back because we've studied it so much. We don't do AE reporting for slight hospitalization unless it's specifically in the protocol that we do need to report it. Our screenings look a lot different. So we're not going to screen someone for a cancer they don't have. So we usually have, I would say, 2 protocols open for like leukemia right now. So we would screen based on that. And our treatments don't include placebo studies like the adult world do. We either give them the standard of care or an investigational arm. This is an example of what is in the protocol that talks about the drug, the dosages, when we need to give them. The pharmacists use these, the nurses use these, me and Wendy use these, the doctors use these. It's just really helpful to be able to see like what.
It's a plan of care.
Yeah, it's the plan of care for our patients, and it's just laid out pretty well. And then this is an example of the roadmap. So me and Wendy based the calendars based off of this. And it talks about, this is an example of a lymphoblastic leukemia roadmap. And it just helps us to determine like what they're in the clinic for that day and like helps with scheduling as well.
Let me so you can see why we do a monthly calendar with the complexity of this, where you have like day 1, day 4, day 8, and you're supposed to keep giving. Do we still give some medication or what are we doing? So doing a calendar for the family really does help them instead of them trying to learn this roadmap. That's it. Yeah.
And industry studies, we do not do any industry studies in the clinic right now. My project has been to try to find an industry study, and it is very hard to find in this field because COG conducts 99% of the research for pediatric oncology being mandated by the government. It would be very hard for another group to come and start a program since this data goes back to like the early 1900s. Industries and drug companies continue to partner with COG to help in the development of new pediatric cancer drugs. So like big companies you would see just partner with COG to try to find like what is going to work best. Like I mentioned before, we don't do any placebo studies, and me and Wendy and the doctors and everyone in the clinic, we try to do more biology outcomes studies than therapeutic studies because there's not a lot known about pediatric research.
So locally, what is our program here? Oops, that's going backwards. I'll go backwards. So we treat pretty much just about any childhood cancer that we're gonna come in contact with. So these are just a few examples, but this is certainly not an exhaustive list of the different malignancies that we treat or that we have treated here. They already mentioned that we currently have 23 COG protocols open, therapeutic and non-therapeutic studies. And in terms of future directions, what are we trying to accomplish here? So our goal here is to provide state-of-the-art multidisciplinary oncology care to all children with cancer in Southwest Virginia and the surrounding areas. We want to be able to provide this care to patients and allow them to stay at home and not have to travel away from their support services. We want them to be able to continue to attend school, to stay with their family and their friends. It's hard enough to be diagnosed with a life-threatening, diagnosis for the child and the family, and then have to move hundreds of miles away in order to get treatment. And we don't want that to be the situation for any of the families if we can avoid that. Right now, we're looking at ways to expand care to the AYA group, and this stands for adolescent and young adult. This is a population that historically has been overlooked. They're underrepresented in therapeutic trials. They have special needs. They're defined as a group between the ages of 18 to 39 years old by the NCI. And their needs are a bit different in terms of these are younger people, so they haven't really been firmly established in terms of careers and that sort of thing as the older people have. A lot of them are still in the process of education, either with college or learning a trade, that sort of thing, and getting established in the workforce. And so they have special needs in terms of survivorship care, educational and vocational assistance. And we're currently, there's the group, a consortium of all of the pediatric cancer treatment centers in the state here. We've sort of formed a group where we're trying to get funding for certain initiatives. And right now, this is the area that we're looking at. And so we've recently reached out to our adult colleagues, and we're investigating AYA peds to age 25. Depending on the diagnosis, there are some diagnoses that would kind of carry over into that age group, where we would have therapeutic trials that would be available to them. And we want to make sure that they have access to those trials. And also in terms of providing extended late effects care and that sort of thing. So there's a new cancer center that is planned to be built. So we're looking forward to moving into and expanding into the new cancer center. Right now, our space is very limited. We have just a small clinic here, which really compromises our ability to expeditiously give care to in certain areas, especially with infusions, because they take up so much time and space in the clinic. We hope that in moving into the cancer center, this is going to make it easier for us to collaborate with the Research Institute and participate in some translational research in that area. Easier access, more space, co-location of services in one place. And we hope to develop combined clinics, easier patient transition between pediatrics and adult services, and collaboration in terms of survivorship, late effects, and AYA. So just in conclusion, childhood cancer is rare, but even with significant advances in survival, it's still the leading cause of non-accidental deaths in children today. Children are not little adults. They have special needs that are specific to them. There are some diagnoses that aren't going to be seen, are going to be very rare in adults, that are going to be more prevalent in children. Research in children is ethically sound with proper provisions for additional protections. The advances in pediatric oncology have largely been made possible through cooperative group clinical trials, and here we participate in the Children's Oncology Group trials. The need for cooperation between pediatric and adult oncology practice to provide optimal care and access to clinical trials for AYA and management of late effects is a need here that we're looking into and developing. And Carilion Children's Pediatric Oncology with participation in the Children's Oncology Group is providing state-of-the-art multidisciplinary care to a full spectrum of childhood cancers and is advancing improvements in pediatric oncology. So that kind of concludes our talk. I think there might be some time left over for questions. And this is another one of our patients here that I put on the screen there just because he looked like he was asking a question.
What a fantastic presentation. If anybody has a question, you can feel free to pop on and ask it or put it in the chat. I do have about 30,000 questions. It's such a fascinating presentation. What is the attrition rate for studies that have follow-up of up to 10 years? Do you lose a lot of people? Do they stick with it?
Well, because I'm very hands-on with our patients, I remind them, even though I'm going to be in touch with you, if you don't come in when your follow-up is due, because it's very, they want it year to year, you don't come in when you're supposed to, I will make a phone call. I will call your mama, I will call your daddy to find you and do it that way. So here we do not lose a lot, but I'm sure larger institutions do. Because in larger cities, people, adults, once they're teenagers, they move, or young adults move or go away and stuff like that. But I've had a few that have absconded on me, and but most of them I can track down, and I just gentle reminder that, we do follow up and that sort of thing. So
yeah, and just because the studies, the patients are followed for 10 years, that doesn't mean that we're not getting results from those studies before the 10-year mark. So the studies will close to accrual, and then so we'll have toxicity data and that sort of thing earlier, and then eventually we'll get survival data. They'll be able to differentiate between arms in terms of what arm is more effective, what arm may be more toxic, and so then that information can be used to develop future studies. Studies that accrue patients faster, like the ALL studies, sometimes those are leapfrog, where the current study is not based on the preceding study, but the study before that. And so that's how those studies are developed, and they can be developed and activated quickly.
Great. There's a great presentation, such important work being done. Comment in the chat. Any other questions? And then I guess my question is, like, who does the training for things like bone marrow aspirations, and how does that work for the CRAs, the CRCs?
Well, we say that we go to the procedures. The physicians do the procedures, but we're there to tell them, like, COG will require, like, they want 10 mLs of bone marrow, but they want it in 4 different tubes. So we're here to tell them, we're putting 2 in this one. We need 3 in this one. So we have from the protocol, what the requirements are. And then as the physician is doing the procedure and the bone marrow is coming out from the syringe, and we put it in the correct tubes. So it can because certain tests require different colored tube tops, things like that.
And that's another reason why me and Wendy really need to know the protocol. So Wendy's been a very good teacher, and I really couldn't have learned it without her.
Yeah. So we as physicians, we don't have to think much. So we go in, we do the procedure, we're the technicians, and they just tell us how much to give them, and we just pass it off, and they know how to divide the sample up and what's required. So
that's really fantastic. And for 23 open studies, that's a lot of keeping track of.
Yeah.
Great.
Yep.
And some of the specimens, like when you have like a brain tumor, like you send a piece of snap frozen brain tumor to the COG place, where you'll have like a leukemia study where you have to send it to the Nationwide Children's in Ohio, and then we'll have stuff that needs to go to our local lab, and then we have stuff that has to go to California. So there's like, the whole section is just, some are more involved in other studies with specimens and stuff.
Right. Well, that's great. Thank you all so much for this really amazing presentation. I think it gave us an opportunity to see into the world of the kind of research you do, and what it's like to be a research coordinator with these kinds of studies and with the IRB process. Thank you. And if there aren't any other questions.
Well, thank
We
you for
will-
having us.
Yeah,
Oh,
thank
yeah.
you. Thank you for the opportunity to share what we do.
You bet. And we can't wait to hear more as the building gets built and you work on some collaboration with adult oncology.
Yeah.
Really fantastic. Well, have a great day, everybody, and thanks for coming.
Thank you.
There's a lot of accolades in the chat if you want to pop in and see them.
Okay.
All right, thank you.
Thank you. There you go. Oh, there's a lot of people here.
Recording.